بسم الله الرحمن الرحيم. الحمد لله رب العالمين. صلى الله وسلم وبارك على نبينا Muhammad. Welcome back to our sessions on pathophysiology of congenital heart disease. We finished most of the parts we needed to talk about. We're finishing today, inshallah, with pathophysiology of left-sided obstructive lesions, namely the mitral stenosis, aortic stenosis, and coarctation of the aorta. We will be talking, first of all, about mitral valve stenosis, and we can divide mitral valve stenosis into mild, moderate, or severe. When we talk about grading mild, moderate, or severe, we usually grade it by mean pressure gradient, MPG, which we measure across the pulmonary valve, whether in the cath lab or by the most common procedure, which is the echocardiogram by Doppler. So if we have mild mitral valve stenosis, regardless of the congenital cause of that mitral stenosis or the association, we're not talking about structure or causes, we're talking about pathophysiology. What does this lesion cause as a pathophysiological effect? So mild mitral valve stenosis, we are talking about a mean pressure gradient of less than or equal 7 millimeter mercury. Okay, so we're talking about a mean pressure gradient of less or equal 7 millimeter mercury. If the gradient is less than 7, then the condition is deemed mild. We have said before that our mean left atrial pressure, normal, is around 6 millimeter mercury. So we would expect in a mild mitral valve stenosis, we expect that the mean LA pressure will be around 13. Okay? So if we have a mean pressure of 13, which means we have about a 6 gradient. If we take the top being mean of 7 here, and this is 13, then we have about a 6 millimeter gradient. We know that our pulmonary artery pressure, or the pulmonary venous pressure here, these are the pulmonary veins coming in, the 4 pulmonary veins. The pressure in the left atrium, if we said it's mild, and it's now 13, mean of 13 millimeter mercury, the same pressure will be also here, mean of 13 millimeter mercury. What is the pressure in the normal pulmonary artery, PAP? A normal pulmonary artery pressure mean will be around less than 25, and most likely it will be around 15 millimeter mercury. If we add the difference, which is the 6 millimeter mercury, to that 15, it may be 25. If we take the higher normal mean PA pressure being 25 and we add the 6, the PA pressure will be, in a mild mitral stenosis, will be maximum mean of around 30 millimeter mercury, which is just above the normal by 5 millimeter mercury, or maximum by 10 millimeter mercury. This mild elevation of pressure in the left atrium, mild elevation of the mean pressure in the pulmonary arteries here. If this is the left pulmonary artery, this mild elevation, I'm going to take away the drawing, you don't need it. You can just follow it by talking about it. So the mean pulmonary artery pressure here is mildly elevated. This combination is not expected to cause significant pathophysiological effect other than just the numbers being higher than normal. So if we look at the left atrium, do we expect it to be dilated or abnormally dilated compared to a normal person? Usually, no, not much of LA dilatation is seen. If any, it could be very trivial. So no effect on the size of the left atrium. What about cardiac output? Since this is a stenosis, it's supposed to be hindering cardiac output. But we know it's only mild, and the physiology is getting over it by elevating the pressure in the left atrium, so it can be, the blood can be squeezed in or ejected in from the atria of the left atrium to the left ventricle. By this, cardiac output should easily go in with no hindering. So we do not expect any cardiac output limiting effect. So no limitation on cardiac output. What about left ventricular size and function? We know that left ventricular function, or ventricular function in general, is dependent on the myocontractility, but also is dependent on volume loading. If you have good volume loading, you have good function. But if you have poor volume loading, you may have poor function, which after loading the ventricle will actually prove that it was not poor. It was only just underfilled ventricle. So we do not expect an effect on cardiac output, nor do we expect any effect on LV systolic, diastolic, or size. Function and size are also quite maintained in mild mitral valve stenosis. Do we expect any congestive heart failure because of isolated mild mitral valve stenosis? No, we do not expect any cardiac failure of any sort, not systolic, not diastolic, not combined. Do we expect any arrhythmias because of that? Since we do not have a severely elevated pressure and no chamber dilatation, especially no left atrial chamber dilatation, we also do not expect cardiac arrhythmias in such patient, unless there are other associations with this congenital mild mitral stenosis that predisposes to any additional complication. But again, if it is just mild, we do not expect, and this is the paradigm that's going to happen. What if it is a moderate stenosis? And when we say moderate, that means the mean is anything between 7 millimeter mercury and less than or equal to 12. That's a mean pressure, huh? Mean pressure difference of anything between 7 or above 7, because it was equal 7 in the mild, to less than or equal 12 millimeter mercury. Obviously here, if we practice the same exercise we are doing throughout, let's take that it is actually 12. So with a mean normal LA pressure of what, 6? Yes, that's what we have said. Then we expect that the left atrial pressure in this patient will be around 18 mean. You see, the mean here will be 18 millimeter mercury, and that's a much higher pressure. The same will go that we will actually now see a mean of 18, again, also in the pulmonary veins, okay, reflecting the high LA pressure. A mean of 18 compared, if we take the gradient now, we said the gradient before was around 6. If we take the gradient now it's what? It's 7 minus 18. Now the mean gradient is around 11. So it's anything between what we said as moderate. Let's say it's a 10, just to make it simple. So moderate, we have a mean gradient of 10. We know that the PA pressure normal is about 15 to 25. We chose last time to take the higher number, 25. So 25 plus the mean of 10, then your PA pressure in a moderate mitral valve stenosis, mean PA pressure will be around 35 millimeter mercury. You see? Now we are in the moderate PA pressure, knowing that a mean of 50 in the pulmonary artery pressure is considered high or severe. So normal is around 20, high is around 50, mean PA pressure, a mean is around 35 pressure. In this stage, you see the mean LA pressure now, which was 6, it's now 3 times its normal pressure. And as a rule in cardiology general, any size or pressure or diameter that increases by 2.5 to 3 times its original size, then this is a significant change. And that's why here, because of this mean LA pressure of 18, we will start seeing at least mild to moderate left atrial enlargement. So there will be here left atrial enlargement, yet it is not severe. It could be mild, maximum moderate left atrial enlargement because of such moderate mitral valve stenosis. Let's move now to the next point. Cardiac output, will it be affected? Obviously, no, because we haven't reached a stage where the right ventricle cannot pump the blood to the pulmonary artery pressure because of pulmonary hypertension, nor did we reach a stage where the left atrium is so dilated and dysfunctional that it cannot actually squeeze the blood in diastole to the left ventricle. So cardiac output, even in moderate mitral valve stenosis, will be maintained. So no effect. When I say X, it means no effect. It doesn't mean that the cardiac output is X, no. So no effect on cardiac output, it will be maintained. Left ventricular function and size are also maintained, no major effect. See, there's always a trivial effect because now we are at moderate, but no effect measurable. No effect that really makes a difference in cardiac output or cardiac function or size of the left ventricle. Do we expect any congestive heart failure because of moderate mitral stenosis? The answer is most likely no. Do we expect any cardiac arrhythmias because of a limited inflow through the mitral valve with a moderate mitral stenosis? Then here we could say plus minus. So it is possible, but not probable. Most likely you will not see arrhythmias in moderate mitral stenosis unless it has been really for a very long time and we have significant left atrial dilatation. Cardiac function also on the right side, we will not see any effect. We will not see cor pulmonale, we will not see significant pulmonary hypertension, but we may start seeing mild elevation of pulmonary artery pressure and right ventricular pressure. If a mean here is 35, we expect the systolic to be around 45 to 50. So your right ventricle in a moderate pulmonary hypertension, RV systolic I reverse it. RV systolic pressure will be what? Around 45 to 50 millimeter mercury, which is mildly to moderately elevated. Yet, no significant right ventricular hypertrophy, no significant dilatation, and no significant effect on cardiac output. This is mild, this is moderate. Now we go to severe mitral valve stenosis, and when we talk about severe, we talk about a mean pressure gradient difference between the left atrial pressure and the end diastolic left ventricular pressure of more than 12 millimeter mercury. We're talking here about a pressure difference of more than 12 millimeter mercury, more like 15 and so. So obviously here we are really reaching very high pressures, and we start seeing pathophysiological effects of such an obstructive left-sided lesion. Let's go to left atrial pressure. It was 13 in a mean of 13 in a mild, mean of 18 in a moderate. What do you expect it here? If we say it's more than 12, probably we'll take a mean of 15. 15 plus the normal 6, we will probably go now and start seeing a left mean atrial pressure of around 20 to 25. Let's say it's 22, just for a number, millimeter mercury. Obviously, now the difference is really getting higher, and you see it doesn't take on a venous side. The atria are non-muscularized in general, quote unquote, chambers, so they do not produce high pressures. So you only need a few millimeters to move from mild to moderate and moderate to severe. You see here, we just needed 5 millimeter mean pressure to move to moderate, and here we needed another 4 to move to severe, because it's on the venous side, on the atrial side. So if we say this is now mean of 22, and this is supposed to be the pressure, or the 6, we have a difference of what? 15 or 16 millimeter mercury. Add that to a normal mean pressure of around, let's say, we took before 25, so 25 plus 16, that's what? 41. It was here 35. Now it will go to 40 to 45 around, let's say. We said 41 millimeter mercury mean PA pressure. If we are going to add now the 20 to make it a systolic PA pressure, then the systolic PA pressure will be above 60, and obviously the right ventricular systolic pressure will also be more than 60 millimeter mercury, and this is quite high. If we take an average systolic pressure of 100, then this is about 2/3 systemic pressure, or above 50% systemic pressure, and now this is quite high, and now we really expect to see changes and differences. So LA size, we said there is mild to moderate LA enlargement in moderate mitral stenosis. Obviously now, in severe mitral stenosis, there will be at least moderate to severe LA enlargement or LA dilatation. So left atrial dilatation is a main pathophysiological effect that we see in severe mitral valve stenosis, and it's going to be at least moderate, if not severe. And how we judge? By measurement, and we take compare it to what is expected normal for body weight and surface area, and we will know whether it's mild or moderate or severe enlargement. But it is severe enlargement. Cardiac output, yes. Now cardiac output can start being affected. It's not going to be affected in terms of being critically affected, but at least it will be moderately affected. When I say check sign here, it means it is affected. It doesn't mean it's good, huh? Just be careful. I'm using it in a bit different way. So the cardiac output is affected. We are going to start seeing less cardiac output, not to the critical stage where the blood pressure cannot be maintained, or the patient may develop symptoms of low cardiac output state at rest, but maybe develop it on exercise for sure. But here we are talking about that the cardiac output will start seeing limitations. Left ventricular volume and function may go down, so because of limited filling. So we do have an effect on left ventricular function and volume, and that's how in congenital mitral stenosis we may see actually hypoplasia of the left ventricle in utero or after delivery. And this is, again, if you really believe in the flow theory, because of limited flow going to the LV, and most of the flow will actually just go through the PFO to the right atrium, causing the smaller LV. So LV function, LV size is affected. LV EDP is not changed. Maybe it's lower, maybe it's higher if the cavity became smaller. So, but we don't care about that now. We're just talking about isolated mitral valve stenosis, severe form, affecting to some degree the cardiac output, limiting LV size and limiting LV systolic function. Congestive heart failure is a possibility. So again, we can start seeing congestive heart failure or cor pulmonale, and arrhythmia also can be seen, and it would be atrial arrhythmia, and most of this atrial arrhythmia will be either flutter or fibrillation because of the severely distended left atrium and loss of conduction pathways and dissociation of those conduction pathways between each other. And now we're going to see each focus just beating on its own, causing the flutter or the fibrillation of the heart. So if we take it further now we have pulmonary hypertension, because RV systolic pressure and PA pressure now, they have, the PA pressure will have a mean of at least 60. RV systolic pressure will be also at least 60. Now with longer time passing with such disease, we will start seeing right ventricular hypertrophy, reaching to all the complications of such disease called cor pulmonale. That means we can go from just simple RVH to RV dilatation, tricuspid regurgitation, low right-sided cardiac output, pulmonary regurgitation, increased systemic venous pressure and venous congestion with all its effect on the body, causing congestive heart failure. Obviously, when it becomes critical or near atresia, then this is the extreme example of mitral stenosis, where there will be significant pulmonary edema, cor pulmonale with it, and decreased cardiac output, severe enough even at rest. Just to finish, would we see pulmonary edema in mild mitral valve stenosis? No. In moderate mitral valve stenosis, very unlikely. In severe, yes, we will see signs of pulmonary venous edema, and actually we will see on the X-ray that the pulmonary arteries actually are enlarged and dilated, and even on echocardiogram. I hope by this I have summarized mitral valve stenosis pathophysiology based on mild to moderate and severe, and based on the mean gradient, the left atrial pressure, the pulmonary artery pressure, the LA size, the cardiac output, the left ventricular size and function, congestive heart failure, and arrhythmias. Can mitral valve stenosis, if it's critical, give us ischemia signs? Well, if the cardiac output is decreased, that's a possibility, but it is not a common possibility. It's actually extremely rare. But for sure, mitral valve stenosis, if critical, and if the baby is born with it, and it's really critical without a significant ASD and without the presence of a patent ductus arteriosus, we may go into cardiogenic shock as a pathophysiology in such rare, extreme situation of near atresia of the mitral stenosis. From this, we will move to subaortic stenosis and aortic stenosis.